Our next speaker is Dr. Akihiko Takeuchi. The EAMOG study with the title Long-Term Critical Outcomes of 105 patients with diffuse-type tenosynovial giant cell tumor, the East Asia Musculo-skeletal Oncology Group EAMOG study.
Thank you for Chairman, and good morning, everyone. Diffuse tenosynovial giant cell tumor, abbreviated DTGCT, usually affect large joint. And in Japan, we experience 200 new patients per year. Most of the patients usually younger than 40 years old. And the problem is the tumor invaded the bone and cartilage, and usually difficult to complete excision, resulted in high local recurrence rate. A recent topic is the newly targeted therapy for CSF1 receptor antibodies. Preliminary report shows amazing response, but now it's under clinical trial in foreign countries. So my question is, what is the long-term outcome in Asian populations, and what factor influence the local recurrence and the limb function? So this is a study for retrospective multinational and multi-institutional to evaluate clinical outcome of DTGCT in Asian populations. EAMOG was formed in 2004 to perform a collaborating study, and now more than 80 orthopedic surgeons participate. And including criteria was this study was histologically confirmed DTGCT and follow-up at least 3 years and no medical treatment. After IRB approval in our university hospital, we send a questionnaire to all EAMOG members. A questionnaire contains several factors, and then we collected data from participants. We evaluate the local recurrence-free survival after the initial treatment and predictive factor associated with local recurrence-free survival and MST score and oncological status. A total of 156 patients from 30 centers, but we need to exclude 41 cases. So finally, 105 patients was evaluated for these studies. We collect data from 8 nations. So this study included 44 men and 64 women. Mean age were 40 years, and mean follow-up period were 18 months. The patient status was primary were 82, and 23 were referred after the recurrence. The most affected site were around the knee joint and ankles. Local recurrence-free survival was 71 in 5 years and 50 in 10 years. We evaluated the predictive factor for local recurrence-free survival in log-rank tests, and only complete resection was a predictive factor for local recurrence. And the initial procedure was mainly open synovectomy in 90 cases, and some cases were treated by arthroscopic synovectomy with or without open synovectomies. And we divided the resection status. Complete was 74 and incomplete 31. And after complete resection, the local recurrence seemed a little bit lower compared to the incomplete resection at the initial surgeries. And finally, oncological status was 47 CDF, NED was 21, and AWD was 37. And the mean MST score at 26. But there was no significant difference in oncological status, but AWD was the same lowest. And the predictive factor of MSTS was only a complete resection. Discussion. This study was from Europe. This study contained 294 cases. And our study was similar to this report, so we considered our results were comparable to other countries. And the authors concluded a balance between quality of surgical margin and function preservation should always be made. And now we are performing, sorry, this slide not works, and a different approach. We are performing investigator-initiated clinical trial using that profile, one of the NSAID. This study now performing in Japan. So medical treatment may keep the stable disease and preserve limb functions. But this study has some limitations. A multi-center retrospective study with no randomization protocol of surgical procedures. And the final decision of the type of surgery was made by the operating surgeon in each institution. So in conclusion, a long-term clinical outcome of the TZCT in Asian populations were comparable to other nations. Complete excision may lead to favor oncological and functional outcome, although the achievement will be determined by the tumor extensions. There seems a role for palliative excision to preserve limb function in those alive with stable disease. Thank you for your attention.
Thank you very much, all the speakers, for keeping to time. We have enough time for a number of questions, so please.
I have a question for the extra-articular resection. And what is your definitive criteria for choosing extra-articular resection, including persistence, joint effusion, or dissemination of the intra-articular region?
Thanks for your question. About 10 years ago, when the tumor protruded in the anterior joint, we worried about recurrence, so we did an extra-articular resection. And after resection, we evaluated a specimen. Actually, we did some histological research to show that there was a very thin membrane covered the tumor. So it not invaded the tumor area. It is very thin, but it works to prevent the tumor spread into the joint cavity. So your another question, so how to evaluate that? We usually use the CT scan and MRI before surgery. And if the tumor mass is not in the joint cavity, and there's no diffuse fluid signal in the joint cavity, we think that the joint is okay. Thank you.
Okay, thank you.
My question is to Dr. Natara. Did you factor in the use of tourniquet in your study when you used tranexamic acid for the limb tumors?
Yes, we use tourniquet in all of this case.
Okay, thank you.
First speaker, that is, when you are expecting a tumor extension anteriorly, naturally it is the patellofemoral joint that is involved. It is the patellofemoral joint that is involved. So you cannot preserve the cordyceps mechanism. So have you, what you are doing about that? You are thinking about the extra-articular resection where the anterior patellofemoral joint is involved. So to have a better that is joint removal, we need to remove the patella also, or cordyceps mechanism. So what is your thought on that? The first speaker.
So if we do the extra-articular resection, we will remove all the distal femur and the proximal tibia and the patella and the tendon, all of that, to remove that, so and then reconstruct that.
Yeah, so the entire patellar mechanism has to be reconstructed. That is, the cordyceps mechanism has to be reconstructed. Are you right? Am I right? Entire cordyceps mechanism is to be reconstructed.
After remove the patella, we usually use the last ligament to replace the extensor mechanism. But actually, the function is not good as if not remove the patella. Yeah.
I'm Dr. Chen from Taipei, and I have a question to Dr. Zhang about the venous thrombosis, tumor venous thrombosis in pelvis tumor. Thank you for your excellent research with Professor Guo. And my question is, which time point do you think is the most highly possibility of this tumor venous thrombus to come out and the metastasis to lung? Is it higher when we do manipulation during the surgery, or it's already start to metastasis to lung at the initial of the diagnosis? Thank you.
Thank you for your question. Actually, prior to the surgery, we insert a filter to the vena cava for all the patients who have who are found to have a VTT in the iliac vein. Second, we have a surgical classification. I didn't have time to describe it very clearly. Well, when the tumors were localized to common iliac vein or below that level, we can do resection together with the tumor or do thrombectomy during the surgery. So we can remove the thrombus in type 2 and type 1 resection. But in type 3 resection, type 3 VTT, when they go up to the inferior vena cava, it's really difficult for us to do that procedure during the surgery. So we prefer other kinds of adjuvant therapy post-operatively, maybe prior to the surgery, to deal with that kind of situation.
So another question, before application of the venous filter, do you have any data that this would indeed reduce future lung metastasis rate, or there's no obvious difference from your experience?
Do you mean the pulmonary metastasis? Or?
Yes, I mean when you might have data before you start to use the vena cava filter before the surgery, and do you have any data compare? Is there any difference between these two groups for pelvis tumor?
Actually, we didn't analyze that data, but we only find that there's more pulmonary metastasis. But we didn't have any experience in any procedure between the before or after the insertion of the filter. Yeah.
Okay, but thank you for your study. It's very impressive. Thank you.
Thank you.
Thank you for all the speakers. I'm Walid from Egypt. It's a question for the same speaker regarding the venous thrombosis. Do you have any method to know if there are venous thrombosis prior to surgery, or this is something that you discover during surgery? Because sometimes when you're doing pelvic resections and you just ligate the feeders, you discover that there is actually tumor thrombosis inside the feeders. And what do you do in this situation? I mean, the first question is, do you have any method to identify this before the surgery and the extent? And if during the surgery, when you're ligating the feeders, you discover a thrombosis, what do you do? I mean, do you keep on going after the thrombus, or do you?
Okay, thank you for your question. For the first question, actually, sorry.
Do you have any investigative method or anything that you can
actually,
know that there is the extent of the thrombosis?
Yes, definitely. This is a retrospective study, but we retrospectively review all the radiographic images of all these patients. Nowadays, we are doing the radiographic evaluations routinely prior to the surgery nowadays, so we can follow our surgical classification, do the corresponding procedures right now. And for the second question, I think we normally we would like normally to remove all the thrombus as much as possible, together with the maybe vascular surgeons. Yeah, sometimes. Yeah.
And you consider this an intralesional resection?
No, actually, we consider thrombus as a whole mass with the tumor, actually, because they are actually connected.
Thank you.
Thank you very much. I'd like to thank all the speakers for their contributions. It was a nice discussion. Thank you very much.
May we have the next 4 speakers take the stage? Thank you.
They'll have to have the photographs. They're coming up.